Hello, we will be speaking about delirium, its screening, prevention, management, and also evidence based nursing care practices that we as nurses can put into practice to help our patients that are experiencing bouts of delirium. To be able to address delirium, we must first understand what delirium actually is. Patients that are experiencing dementia, they can have these quick fluctuating episodes where they can have an altered ability to understand their surroundings, to communicate, and sometimes this can just be a downward spiral for the patient that's resulting in also a functional decline. They may lose some independence. They may be having a step now to be institutionalized, and it also might be a sign that they might be close to death. Delirium is a common problem among hospitals and long term care facilities, especially for those patients experiencing a progression of dementia. It can be a scary situation. It often is costly. It can also be life threatening, not only for the patient, but for those people that take care of them. Some impacts that delirium can cause can be falls. They may have to ask to use a physical restraint. It may increase the amount of time that a person has to stay in the hospital or even lead to transitioning their care to a long-term care facility. It may complicate their already in place medical conditions, and sometimes it might cause a long-term disability. It also will cause emotional toll, not only for the patients, but their caretakers and also their families. Delirium is also something that can be prevented usually. It's not an inevitable. It doesn't mean that, oh, well, this is just something that we're going to have to deal with. Sometimes a medication can be the issue, such as a sedative, hypnotics, narcotics, anticholinergics, corticosteroids, or even just polypharmacy. If they have too many medications that are treating the symptoms of another medication, or medications that are coming together to interact to cause this bout of delirium. It could be that they're withdrawing from alcohol or a drug problem, and all of that can also increase the chances of delirium. I'm certain we've all had a patient coming down, detoxing, that is seeing things or thinking that you're somebody that you're not. I once had somebody accuse me of being the cop that had arrested them the month before, never having seen that patient before, just simply because they're coming off of alcohol or drugs. But especially in a person that has impaired cognition already, and then they're also progressing and becoming even more confused. These sensory impairments, like being their ability to see or hear, their ability to not be able to process what is being said to them, even more so than when they had dementia. And also some other medical conditions can increase the chance of delirium. So these systemic processes can be a variable that will cause delirium to present. And if we don't see these early on or know that these processes can cause delirium, it may not get identified at the beginning stages and then may progress into a full-blown delirious state. Again, like we said, that can cause falls, further costs, and just more harm mentally and physically to our patients. So, what do we do? Again, as nurses, we always are trying to look for what we can do. And sometimes that it involves not having to call the doctor right away. It always comes back to, what do we know? Assessment. That's what we always had to do. That's what we've learned in nursing school, what we've learned in praxis. We have to assess our patients. Because if we don't assess, we don't know where they started at, and we can't have this baseline to compare. So when our patients are admitted, and also throughout their hospital stay, not just that first time, but a continuous amount of time, that the hospital might have in place. We have to assess our patients to help prevent these bouts of delirium. Having a standard delirium screening for your institution has been shown to have an effect that helps fill that gap between the treating and identifying of delirium. Being able to quickly recognize that our patients are starting down a course to a delirious state can allow for patient safety and prevention of further decline of our patients. Some interventions. Studies have shown that if a person is prone to this delirious state, so like we said, certain medications, certain conditions such as dementia that we're kind of focusing on here, we can improve our ability to take care of those patients. If we focus on the end result, being that let's just let them get into their delirious state and then treat them there, it's not as effective as if we try to nip the situation in the bud. We want to look for those little bitty steps, those possibilities, those situations that are prone to progress to delirium, rather than, like we said, just let them get to that state and put themselves in harm's way. So rather than just think of one way, such as just medication or just restraints or something like that, we want to look at a multifactorial approach. We want to look at not just meeting this situation with one answer. We want to look at a myriad of answers. So, since we need a myriad of answers and we need a myriad of interventions, that means we need lots of different kinds of people. And involving a multidisciplinary team is important. So, not standing as an island of a nurse, we also need to involve our support staff, our doctors, our therapists, our social workers, the family. We need to look at the whole picture in helping this person not progress into that state that can be very harmful. The best treatment, prevention. We want to quickly identify this person's progressing into this state. We want to make sure their environment is safe. What can we do to prevent that fall? What can we do to prevent them from going into an area that can cause more harm? How can we prevent having to put them into restraint? And then initiating this delirium prevention bundle. If we see these couple of factors popping up, we're going to put them on a delirium prevention bundle, just like you would put a diabetic on a hypoglycemia or hyperglycemia prevention bundle. There would be a set of steps put into practice by your institution that'll probably be pretty similar between institutions, but something that we have sat down and agreed upon as policy that if we see some certain factors pop up, this is how we're going to address it to prevent that patient from progressing into delirium. Delirium prevention bundles rely on recognition and prevention as being essential. That means that as nurses, we have to be trained to see as such. There's an example of a Korean group of nurses that weren't too comfortable with the situation and would often have their patients progress into delirium, where the families were providing a lot of the CNA work. And these poor families were also having to deal with these states of delirium. And just a simple answer of taking those nurses and actually training them in-house, both by telling them, hey, this is what to look for if delirium is on the horizon. And if and when we can't prevent it, here is how to effectively address it. And lo and behold, those nurses with that information felt more in control and had more ability to not only show compassion for their patients, but to be able to see these things pop up early on and address them. So this effectiveness of having these things put into place, having your staff educated, will decrease the possibility that you're going to have them progress into delirium. Just like this study showed here with Smith and Grammy, just by putting this process into place, they reduced their delirium by 78%. That is an enormous reduction, even a reduction by a couple percent, a lot of the times, is something to be documented. But to reduce it by almost the majority, just putting these steps into place, prevention is actually the key. So, what might a delirium prevention bundle look like? Some evidence-based nursing interventions, i.e., nursing interventions that we aren't just coming up with off the hip. These are ones that have been put into place, have been studied by methods, looked at data-wise, have been analyzed by informatics, and have been shown, yes, these actually work. We don't just say they work. These are the interventions that actually have some science behind them. So we are going to, as caregivers, be educated on these measures as well as the signs and symptoms and conditions that would warrant this immediate intervention. We are going to cease sedation for mechanically ventilated patients. This prevents oversedation and encourages spontaneous breathing. Staying on top of the pain. Unrelieved pain actually can cause post-traumatic stress, which we've seen in people that have gone off to war. This is just showing the amount of also mental anguish that we can put on our patients. So just asking about pain. And if we can't ask a person that has dementia about pain, using those tools, those assessment tools to look at their pain, like we had seen in some of our video training, looking for grimace, looking for them vocalizing, all those ideas. If we can't actually ask them necessarily, we as nurses know that we can look at physical manifestations of pain. So early mobility, we want to get them up and moving. We want them to prevent that muscle wasting. We want to deal with sensory stimulation, so overstimulation and also understimulation, making sure that they are able to sleep. We want to get their environment such that it's not triggering them into these bouts of delirium. And just easy to do. Decrease noise and lights at nighttime. Cluster our care. We've been taught that before. Just making sure that, hey, try to knock out what you can, not putting them in a situation where they're going to be too sleepy, but we want to knock out that care in small little sections so we don't have to bother them while they're sleeping, and try not to give them certain medications like hypnotic agents after 2 a.m. Some other preventative interventions, easy things to do without an order necessarily, making sure that we're reorienting our patients. Hello, Miss Smith. Yes, you're at XYZ hospital. It's a great Monday today. Just easy, not correcting necessarily, but just getting them back to kind of their baseline so that they know that they're safe. Making sure that they are adequately fed and hydrated. So really taking the time to sit down with our patients, or making sure that the person in charge of that is trained and knows the importance of taking the time to maintain their nutrition and hydration. We need to focus our treatment on identifying and managing these causative conditions. We need to provide supportive care. We need to prevent complications. And finally, reinforcing these preventative interventions, not just with ourselves, but also our support staff, like our LPNs and CNAs, with our therapists, and even with the family, because they are going to be integral in helping us with our patients. So what are some specific things that we can do to prevent sensory stimulation? Making sure people have their proper visual aids and hearing aids. Are there glasses on them when they need to be on them? Is their hearing aid tuned to such that they can actually hear, or not hear too much, that not too loud? Trying not to put them in restraints. I know for me, my 5-year-old, if you try to keep her still, it just makes the situation worse. The patients might buck, they might try to get out of bed more, and it also might actually cause a fall because they're not able to move like they need to, and they feel trapped, and that can cause stress and anxiety, or even just fear. Making sure that their lights are on during the day and off at night so that their circadian rhythms stay correct. Make sure that they're up out of bed for mealtime so they get up if possible, or we move them to a way we can move them, maybe like a wheelchair or something like that, and create a routine. Also at night, like we said, just make sure those lights and TVs are off. TVs, and not just TVs, but now we have to deal with also tablets and iPads, that the blue light that we've known that can cause problems with sleeping. We want to uniformly look at trying to keep those off after 9 p.m. and also reduce noise. So if we can turn down alarms, not so we can't not hear what's happening, but making sure that these people get at least 4 to 6 hours of uninterrupted sleep, allowing their bodies to go through that full cycle, the non-REM and the REM sleep, at least for those amounts of hours. That would give them at least 2 good cycles of sleep. And also having things to frequently reorient them, like we said, not only just us verbally telling them, but a clock, a calendar, a picture of the president, a picture of the season, decorations when appropriate, anything to help our patients keep it kind of at the back of their mind what time it is. So what kind of medications should be used? Because yes, sometimes medications are needed. Haloperidol is kind of the gold standard. It's our first approach. It's a cheap medication, a commonly used medication. And even though we want to try to prevent using non-pharmacological interventions first, so adjusting the lights and such, haloperidol has been shown to reduce the severity and duration of a delirious state, but it should be used with extreme caution in the elderly. Medications used to treat delirium increase the mortality rate with the geriatric population, and the use of these medications to combat delirium can further obscure their mental status and make it harder to monitor a change. If you've put them into this zombie-like state from a haloperidol, you may not know actually what's going on at the base of the problem. So again, we want to do those things like keeping the lights down, making sure that they're fed, making sure that they've been asked to go to the bathroom. All of these need to be handled prior to forcing a medication upon them. So the most popular delirium prevention program is called the Hospital Elder Life Program, or HELP. It includes using multi-approach interventions that are cost-effective and improve patient outcomes. Just like we said before, dealing with the environment, making sure they're fed, all of these lots of different interventions that are low cost to approach the problem and prevent the problem and address it if necessary. We need to make sure that our nurses are educated. We can give out and educate our nurses on assessment tools, quick little check in the boxes, things that we've seen before in our charting programs, or something that we can keep on hand, maybe with a laminated card or something that we can, and also use to move that value between shifts. Oh, my patient was at this value in this assessment tool. Oh, good, now I know what to compare it to. Now they've changed by a couple of points in their value. So what does that mean? Making sure we are regularly monitoring for those early signs, i.e. looking just for agitation, just something, bothering them, a cognition change. They may have gone from knowing what day it is and now they don't. We need to put those interventions into place immediately. And we got to know the baseline. We don't know that Mrs. Smith not knowing what month it is an issue if we don't know what she normally knows. And if a patient is in a state of dementia, then we may have to speak with the family for that information, especially again at the beginning, at the assessment. So how can we assess? We want to look for changes in all of these processes, their ability to pay attention, their ability to communicate. What do they remember? How are they able to reason? How are they able to move through a process of thought? And also, what are their thoughts? And we have these tools to use to help us to know our patient's status. And it depends on the healthcare setting on what kind of tool that we're going to use. Using direct observation and also very structured questions is highly recommended. We want to make sure that all of our staff are asking the same amount of information, the same kinds of information, and using the same words, and also looking for the same things. So if I look for a grimace, according to my policy in my institution. I want to make sure that the next nurse is also looking for grimace and that the CNA is also looking for grimace, that everybody's looking for the same piece of information so that we can actually compare them. So here's a couple examples of tools. There's a confusion assessment method, or CAM, highly popular in lots of settings. According to our text, considered to be the best method. It's used to identify an acute, i.e. a quick bout onset, one that's coming on quickly, has kind of a rapidly changing attention and also a change in their level of consciousness. You can't arouse them. They're not answering to their name. They're not answering to your touch. And it's an increased amount of disorganized thinking, which may be confusing if someone has dementia, because they already might have a bit of disorganized thinking. So that, again, super important that we have to have the assessment baseline. There's a confusion assessment method for intensive care unit. This is one specifically designed for patients on a ventilation system and also just in an acute situation. And this is important because sometimes these patients in ICU, if we are not managing their delirium, they could progress to a state in which they would need that long-term care. There's also the delirium observation screening scale, again, used in acute care, and this is based on a system of the diagnostics for mental disorders. We also have the intensive care delirium screening checklist. This is used in ICU and ED. And then some more specifically for what we're talking about for people with dementia. And these, you've seen these before. These are just these cognitive exams looking at the ability for the patient to interact and perform tasks. And then you can also use what's known as the minimum data set in conjunction with the mini mental state examination. This also includes a specific delirium assessment section based on those previous assessment tools we talked about, the CAM signs and other symptoms of delirium. The confusion assessment method for the ICU and the Richmond Agitation Sedation Scale, or the CAM ICU and the RAS, we're looking for inattentive and disorganized thinking, and looking also as the patient, how deeply are they sedated? How are we able to get them to wake up? Do they respond to pain? Do they respond to sound? Do they respond to touch? So we use the RAS for looking at arousal, and we use the CAM ICU to look at patients that are critically ill for delirium, those really acute bouts of delirium. And the nice thing about this is it's super fast to administer. And here they are. We're looking at how much they want to kind of fight back. Are they agitated? How restless are they? And then looking at how sleepy they are. Are they not able to be aroused? These two items together can give us our RAS score, and then we use it in conjunction with our flowchart here for the confusion assessment. And these two items together can help us come to a conclusion about where our patient is in the progression of a possible state of delirium. So, unfortunately, some patients never recover to their baseline level of cognitive functioning. Sometimes after experiencing delirium, we may see subjective memory complaints, ability to not be able to know items about themselves, be able to report things about themselves. They may do more poorly on these different tests that we try to administer to them. They may not be able to pay attention as long as they used to. It may take them a longer amount of time to process something, and their score on those cognitive exams, again, is going to be reduced. So these findings show that delirium can actually cause direct neurological injury, which can lead to persistent cognitive impairment, making it so more important that we make sure that we catch this early and prevent this to preserve what mental capacity our patients are working with. We want to keep that quality of life. So in conclusion, delirium is a serious situation. And even more so, a preventable situation. It's a serious cause, complication in a hospital for an elderly person. Delirium can present so differently between patient to patient and is often underrecognized and underdiagnosed. It needs to be treated as a medical emergency, not something that's just a bothersome outcome. But what is actually happening? It should not be happening. What is going on? Do they have an infection? Is there medication that's involved? Are they hungry? Do they have to go to the bathroom? What's happening that's causing them to progress to this state that they are not as manageable and, like we said, can actually cause neurological damage? So, as nurses, we need to be educated on what signs to look for so we can help prevent the process early on and give them an effective treatment that can help prevent harm to them and harm to others. And also, unfortunately, to look at it this way, to be more cost effective, and make care in our hospitals and long-term care facilities and educating our families about possible home care more safe and effective for our patients.